Hello and welcome to our very first lecture for general orthopedic assessment. So today we're going to go through the basics of what orthopedic assessment is, and we're going to do a tissue anatomy review. So just to make sure that we're all on the same page of why muscles are different from tendons and ligaments, why tendons and ligaments are different from the joints, and we're going to review the basic anatomical features of each type of tissue, just to make sure that as we proceed forward, that we're all using the same terms when we're going through our assessments. So first off, we want to differentiate tissues. We're going to look at muscles, joints, tendons, ligaments, and then fascia we're going to leave until the end of the course in the final module where we are bringing all of these concepts together and putting that ortho assessment together from top to bottom. So muscles. Hopefully everybody already knows the basics about muscles because you're coming in with your prior certifications in equine bodywork. But as a reminder, there are three types of muscles in the body: the skeletal muscle, the cardiac muscle, and the smooth muscle. For this course, we're going to be primarily concerned with the skeletal muscles. So we want to talk about the differences that they have in terms of contractility and where they get their nerve impulses from. So skeletal muscles are voluntary, meaning that nerves in the somatic nervous system, the body nervous system, send signals to make them function. So muscles do not contract on their own, even reflexively. This is still a signal that is coming from the brain or the spinal cord to contract. This is very different from the cardiac and the smooth muscles that are involuntary, meaning they're controlled by the autonomic nervous system. Generally speaking, when we look at the configuration of fibers from each type of muscle, we can see that the cardiac and the smooth muscles are organized a little bit differently due to the nature that they contract in a global sort of manner like so, versus skeletal muscles, which typically are pulling in a more straight line of pull. As is seen here, how we can see how these fibers are striated and quite close together and arranged longitudinally. As I said, in this course, we're focusing on the skeletal muscles. So reminding ourselves of the main function of the skeletal muscles is to enable the horse to move. They also play a very essential role in respiration with all of, in conjunction with the abdominals, the intercostal muscles, the scalenes. Lots of muscles are actually helping the horse to breathe as well. Muscles are also important for maintaining posture and balance. That is how the horse gets around, how the horse is able to stabilize themselves on various surfaces is due to the muscles' ability to contract and stabilize and then relax when we don't need them contracted. Muscles also protect all the vital organs in the body, so they act as this lovely covering for all the deeper internal structures. Looking at the anatomy of the skeletal muscle, I hope that none of this is new information, but simply a reminder that within every muscle bundle, there are many, many smaller bundles that are then segregated even more bundles. So we have this complex system here. When we look at one muscle fiber itself, we know that there's going to be multiple structures deep inside that are helping this muscle to contract. The physiology of the skeletal muscle is voluntary contraction, as we discussed, meaning controlled by the central nervous system, i.e. the brain. Typically, insertion will move towards origin in those longitudinally arranged fibers. There are some exceptions, however, when we have pennate-shaped muscles, such as the gluteals or the dome of the diaphragm, where they're not going to be pulling in a straight longitudinal line because they're shaped a little bit differently. What I'd like to talk about today in this picture is beyond the obvious fact that there's so many different bundles of fibers within bundles of fibers, is that we've got arteries, nerves, and veins actually coming in deeply there and innervating within the bundles. So within every single bundle of muscle tissue, we've got thousands and thousands of nerves and blood vessels actually coming in and through. And this is why it's so important to make sure our assessment is including muscles as well as the other soft tissues, because we want to make sure that we're getting adequate blood flow to the region. Some characteristics of skeletal muscle: they are excitable, meaning they can respond to stimulus. They're contractible, which means they can shorten, okay, in response to stimulus. They can extend. They can do the opposite, which is really nice because they can contract up really tight and then they can release and extend. They can tend to be more flexible than other types of tissues. They're a little more stretchy and elastic, and they have that abundant blood and nerve supply that we just saw on the last slide. So muscles are made up of primarily collagen, which is a strong fibrous type of collagen. This is what provides structure and strength to the muscle. So without these collagen fibers, the muscle would be less taut and less pliable. They're also made up of elastin, which gives them that pliability and stretch capacity. So we've got this nice blending of these two main types of structural proteins that are making up the muscle. So I wanted to talk a little bit deeper about the difference between collagen and elastin, because it becomes very important when we're dealing with injuries, soft tissue injuries, and understanding the different types of tissues and why they are have such different healing times and why the presentation is quite different. So when we look at collagen, this is a group of proteins found in pretty much everything: muscles, tendons, ligaments, blood vessels, bones, skin, in varying ratios depending where they're at. Collagen is one of the most abundant proteins in the body, and it is generally arranged longitudinally in structure. So we can see on the right here, this is a microscopic image of collagen. We can see how nicely packed and tight and dense and straight those fibers are. This is providing really nice tensile strength, okay? I have it there. That structure of the collagen governs its function. Because of its configuration, arranged longitudinally in these straight lines, we get strength and integrity to tissues. Conversely, we have the elastin. Elastin is another protein that's produced by fibroblasts, and it creates sort of this network of fibers. Now, elastin is 5 times more stretchable than collagen, which is really cool. That's why when we have elastic fibers, things can come back to neutral after being overstretched. So if we look at the sort of cellular makeup on the right here, it's very different from the collagen. The elastin's arranged almost in this web-like structure. And the reason for this is that it is able to be a little bit more pliable in various directions and then return to its regular form. The structure of the elastin being so different and web-like is what gives it a functional ability to expand and retract. So these two are very, very different. And hopefully that imagery helps you to understand why tissues such as muscles, which is what we're talking about right now, have this ability, because it has both collagen and elastin, have the ability to be strong, but also be flexible. Whereas when we talk about ligaments, for instance, those have less elastin. So we have more dense collagen in a ligament, which is why it doesn't always return back to its regular shape when it's damaged, and it also has less blood supply. So each muscle fiber is comprised of a number of myofibrils, which contain what we know as myofilaments. So coming out from this would be our myofibril. And then if we took a closer look at the myofibril, we could see all the different filaments that are allowing for contraction to happen. Now, I'm not going to go through the entire sliding filament theory here, but I have connected you with 2 really good videos if you need a refresher on how it is that muscles contract, how the filaments slide over each other, and then how they release and lengthen. The sliding filament theory is the mechanism that is executed every time we have a contraction and relaxation cycle, excuse me. So what I'd like you to do, if you don't remember what's happening at the time of a contraction of a muscle tissue, I would like you to go and watch these YouTube videos to remind yourself what's happening. Because when we come across a muscle that's in a chronic state of contraction, because when we have a muscle in a state of contraction, we know that there is no slide and glide occurring between the filaments, which can also cause a lot of disruption in the chemical mediators at the site. So the next thing I want to talk about is the ECM. That's the extracellular matrix that is around every single muscle cell. Now, the matrix is just as important as the muscle cell, and I think is often not thought of as important. But when we're actually assessing muscle lengths and doing stretch tests, we're also assessing the ECM, and we're getting a sense of what the integrity of the ECM is like and what the health of that is. The ECM is really important because this is what surrounds each and every cell. And in the ECM, we have a number of other cells that are helping to support the myofibrils. We can see in this photo, just the main take home here is the collagens being on the outside there. we've got our sarcoplasm, and then here's our muscle cell. So if we were to think about the muscle cell being here and everything else being on the outside, and this is all bound by water as well. And we can start to realize that there's actually a lot of really important constituents on the outside of the cell. So if we have an area that is in a state of chronic contraction, we would also know that there's going to be a contraction around the extracellular matrix and perhaps a reduction in hydration and or the ability for new cells to be getting made. So common muscular dysfunctions from a bodywork perspective, because there's very, very many muscular dysfunctions. We're just talking about the ones that we are going to be coming across in our practice. The most common things that we're going to see are going to be the hypertonicities. So just tight muscles, spasmodic muscles, perpetually sustained states of contraction. We're also going to see strains. So that's tearing of the muscle fibers. We typically see trigger points in regions of dysfunction. And then we see atrophy when there's been injury or there's imbalances that have gone on for a severe amount of time. We're going to start to see atrophy in the muscles as well. Some of the major indicators of injury is heat, swelling, tenderness, loss of flexibility, meaning we cannot stretch those tissues without a pain response or without causing more harm. And sometimes the horse will have altered gait, depending on the severity. If it's just a simple grade 1 muscle strain, we're likely not going to see any major lamenesses. But if we're getting into the grade 2 and grade 3 strains, which are, partial tear and full tear of the muscle, then yes, we are going to see movement challenges, which probably show up as lameness. The important thing to always ask yourself when it comes to muscles, and when we find hypertonic areas or areas that are atrophied, we need to ask ourselves why. Because muscles are voluntary. Remember what we just said about the brain is sending the signals to the muscles to contract. So if a muscle is in a state of dysfunction or contraction perpetually, we must ask ourselves, why is the brain sending these signals? There's always a reason, okay? We just have to figure out what it is. So how do we assess muscles? In this course, this is going to be part of your case history questions. I always ask if the horse has had prior injuries. So if there was a muscular injury, I would hope that the owner would write that in their intake forms. We're also going to use observation to assess the muscles, looking at areas of tension or rigidity, looking at how the horse chooses to stand, posture, and any other lines of force that are observable in standing. Next, we're going to use our gait evaluation. We're going to watch the horse in movement, and we're going to pay close attention to the muscular regions and to see if there's tension in any of the muscles as the horse is moving. Then we're going to palpate, okay? If we're looking to assess the state of muscles, we must always palpate the muscles, and we are searching for areas of tonicity or flaccidity. And then we can do stretch tests. If we are feeling like there may possibly be a muscular dysfunction or a muscle post-injury, we can do a stretch test to see what the state of the flexibility of the muscle is. Okay, the next tissue we're going to talk about is joints. So joints are very different. This is two bones that are meeting to form an articulation. Joints are responsible for all the movement and stability in the body. They're moved by the muscles. Joints are generally classified based on their structure and function. So within the structural classification, we've got fibrous, cartilaginous, and synovial joints. This is structurally classified based on the material that's composing the joint and the presence or absence of a cavity in the joint. The functional classification is going to divide them into three categories: synarthrosis, which means no movement available, such as like a suture joint, and amphiarthrosis, where there's some movement permissible, like symphysis joints, and then diarthrosis would be our synovial joints, where all movements are permissible. Looking further at the types of joints, we have our fibrous, cartilaginous, and synovial. Fibrous joints are held together by connective tissue. Fibrous joints have no synovial cavity. So they're actually bound together directly, which is very different than the synovial joints, which we'll talk about later. So an example of a fibrous joint would be the suture joints in the cranium. So there is no joint capsule between sutures in the cranium. They are bound together by this fibrous connective tissue. Next, looking at cartilaginous joints, these are held together by cartilage, and there's still no synovial cavity. So an example of those would be the symphysis joints, the intervertebral discs. So in the spine, we have our intervertebral disc, the disc connecting with the bone, that is an intervertebral symphysis joint. Symphysis joints have a little bit of movement, but still no cavity. Lastly, we have the synovial joints, which is what we're going to be focusing on in this course. Synovial joints have a synovial cavity. So there's a cavity between right here. And they have a joint capsule that goes around, as well as accessory ligaments that are attaching the joint together. Synovial joints are everywhere in the body. The most common ones are the shoulder, the elbow, carpus, hip, knee, stifle, hock, fetlock, pastern, coffin, and each single spinal segment. So for this course, we are going to be studying the synovial joints. Let's look at the anatomy of a synovial joint. In the synovial joints, the bone ends are covered in cartilage, which is visible here, okay, just by the blue. There would be cartilage around this bone end and cartilage around this bone end. Then they're connected together by a joint capsule. That will be here, around. This joint capsule or forms a joint cavity, which is filled with synovial fluid all through here, okay? This capsule is what produces the joint fluid, also known as synovial fluid. This fluid is the life-preserving nutrition for the joint. So without synovial fluid flowing between the joint surfaces, that joint would not get the proper nutrition needed to sustain healthy, optimal life. So we really want this capsule to be intact. We want there to be enough space between the bones so that fluid can flow freely between and feed that articular cartilage, as well as feed the bones. The capsule is composed of mainly collagen. So remember, collagen's really strong, generally arranged longitudinally. It provides a lot of tensile strength, okay? So this allows the joint to have resistance to dislocation. The joint capsule is that deepest layer of protection for the bones. If the capsule is perturbed for any sort of reason, of course, we're going to see differences in the ability of the joint to move. Articular capsules also have ligaments that hold the bones together. So coming out of the capsule in the various joints, we're going to have ligaments as well that are actually blending with the capsule and then inserting onto the various bones above and below. Synovial joints are capable of the greatest amount of movement. However, the more mobile a joint, the weaker it can be. So this is why synovial joints are challenging, because they're great because they allow us a ton of movement, lots of degrees of motion, but it's not so great because the more motion that's available, the more potential there is for injury. I wanted to look at the nerve supply next, going into synovial joints. So if we look here, I've highlighted in red, I just want you to be aware that as well, we have a blood vessel and nerves coming in and also feeding that capsule. There are many nerve endings that are penetrating through the capsule inside that synovial cavity, and those nerve endings are responsive to the degree of movement and stretch in the joint. So they're really there to protect the joint from overstretch. All of this information is relayed to the spinal cord and brain, which then may respond by sending impulses to nerves, telling muscles to contract. So thinking back to our muscle lesson about why are muscles tight, we must always ask why. This is why. So we want to know, is that muscle spasming around the joint because there's potential damage in the joint? I don't know that unless I'm able to check. And this is the essence of motor control, is starting to understand that the nerves that feed the capsule are also sending messages all the time, and those messages go to the brain, and then the brain may send messages out to the muscles to contract or to relax. So it's almost like this continuous feedback loop that's going on at all times. But of course, with injury, the brain is going to be getting signals from the capsule that there's potential danger detected, and then it may send those signals to the muscles to contract to protect the area. So the arteries in the area are always going to be accompanying the nerve and vein. Obviously, arteries bring blood. There would be a vein, they haven't showed it here, coming out as well with this bundle. The veins are going to be removing waste products from the tissues. And then it says here, the arterial branches of many different arteries come down and they kind of join together before they penetrate through that capsule. The articulating portions of a synovial capsule joint receive nourishment from the fluid, whereas all other joint tissues are supplied by the blood capillaries. So what that's saying is that all of the other tissues, being the bone, the capsule itself, are supplied by blood capillaries. Next, we have to remember that around every joint, synovial joint, there's going to be bursas, and they're strategically placed underneath tendons and between areas of high traffic. So the purpose of the bursa is to reduce friction. The ones that come to mind most commonly for us humans is we have bursas under our kneecaps, we have bursas in the shoulder, and these are to protect these sort of high traffic areas from compression. And they're also there to protect from external injury. Most commonly, bursas are found between tendons and bones. They're there because their job is to reduce friction of the tendon sliding over the bones. They're almost there to like give a little bit of a cushion so that we don't get this like consistent friction of the tendon over the bone. Next, we want to talk about the tendon sheath, okay? That's going to be coming off whichever muscle it is that's inserting. We're going to have a sheath around the tendon, and these are tube-like bursas. So it's kind of same material as the bursa. Same goal is to provide cushioning and protection, and they're covering those tendons so that we can reduce friction. In us, we have multiple tendon sheaths around the muscles that feed into the wrist. So in our wrist, we've got tendon sheaths on every single one of our forearm flexors. We've got big tendon sheaths going to the thumb. These are all here to sort of promote that slide and glide and reduce friction. So as you're starting to realize, joints are a very complex system. This is why I'm doing a whole webinar on this, just to remind everybody the importance of the synovial capsule, the importance of the synovial fluid. And what my goal is in sharing the assessment with you is so that you may determine if there is a joint issue, and then you may actually apply techniques that are more relevant to joint tissue rather than muscular tissue. So now that you're understanding the intimate anatomy that's existing, it's pretty obvious why you can see how dysfunction in a joint could cause so many issues, because we've got the blood supply, the nerve supply, we've got the nutrition that could be affected to the joint, we've got the bones themselves, and then we've got the muscles that may be protecting, we've got the tendons that may be irritated, and potentially the ligaments that would have been damaged if there was an injury. So joints are complex. There's many moving parts to assess beyond just the bone ends and the muscles. This is why range of motion testing is critical. Without the range of motion testing, we have no information regarding the state of the joint health. Next, we're going to look at the types of synovial joints. The most common ones are the planar, hinge, pivot, condyloid, saddle, and ball and socket joints. I've given you a human diagram because I just really like how simple this one is to show you the different axes of motion available at the various types of joints. Your homework this module is going to be to go out yourself, find each type of joint and describe what movements are available. So instead of me telling you what types of movements a ball and socket does, I want you to actually make sure that you've gone out and found that information and written it down and submitted it as part of your homework. Okay, so now getting into why exactly it is that joint range of motion is so important. Through range of motion assessments, as well as other questions and physical assessments, like we talked about the case history and the muscular palpation, therapists are able to determine what type of treatment is going to benefit their horse, such as, does the horse require stretching, or do they require strengthening, or do they require joint techniques? So you won't know that unless you assess all the tissues and come to a determination. The range of motion values also allow therapists to determine whether the joints are mobile enough to complete activities for daily living, okay? So for example, the carpus, so think about the knee of the horse, the front knee. The carpus needs roughly I've put in bold roughly. I don't like using degrees because they vary with every single horse and every single textbook. So roughly 75 to 90, or is able to fully close. So 75 to 90 degrees of flexion is required to be able to trot over poles, whereas roughly 90 to 120 of carpal flexion would be required for jumping. So this is a big difference, right? So if we're just needing the horse to be able to walk over poles or at the height of a pole, then these would be the goals that we're aiming for. But if the horse is going to be required to be jumping, then we want to ensure that that range of motion is actually available in the joint, and we want to direct our treatments towards that. So understanding the daily life and performance demands of the horse, and then matching that up to what the joint requirements would be, is a really valuable skill as a therapist. I wrote there, don't get hung up on degrees. The way that I assess is just working into easeful versus limited. So we always want to make sure that the range of motion is equal. Okay, when we bring a joint to closing and we bring a joint to opening, we want to feel equal ranges. We also want it to feel easeful, both directions, and not limited. So some common joint dysfunctions from a bodywork perspective, again, things that we're going to see in practice pretty regularly is going to be osteoarthritis. So that's just arthritis of the articular cartilage, articular surfaces of the joint. We're going to see subluxations and destabilizations, depending on if it was a traumatic fall that the horse went through. We might see synovitis. So thinking about your any of the Hawk pathologies, OCD, we likely are going to have a synovitis with that as well, because of those joint surfaces have been so irritated and inflamed. The tendon sheath and the bursae may be also affected when it comes to those types of pathologies. And then capsulitis is pretty severe. That's when there's inflammation of the joint capsule itself, and usually it swells quite a bit and is quite visibly obvious. I would say for myself, the ones I see the most are these top two. So the OA and then the subluxation or destabilization. I have a note here. So injury, repetitive strain, or poor biomechanics can all predispose the horse to any or all of the above. So prevention is always better than treatment. If we can educate our clients on proper biomechanics, the importance of periodizing training so that they're not overtraining or undertraining depending on their sport, we can potentially prevent a lot of these arthritic changes or destabilizations from happening in the first place. And where it comes in is you being able to assess the joints and be able to report to them that you're seeing some dysfunction already and what we need to do in order to promote better health for the horse. Indicators of injury when it comes to joint tissue, heat is not always palpable. Depending on how deep the joint is located in relation to the muscles, we might not always feel heat, okay? Especially in the SI region or the hip, because there's so much dense tissue around those joints. Palpating heat is not always your most reliable way to assess that. Again, possibly swelling, but we may not see it. Tenderness and pain with testing will be there. Okay, if there is a joint dysfunction, there is going to be tenderness and aversion to testing. And there will be a loss of functional range of motion. So if the joint is perturbed, we are not going to have full range of motion. Sometimes we'll see altered gait in the form of lameness. Again, we must always ask ourselves why. When we see these types of signs and symptoms presenting, we need to ask, why are they presenting that way? Because joints are typically involuntary and they are moved by muscles, which are voluntary, we must ask why the brain is sending these signals again to the muscle. There's always a reason. I'm going to keep saying that every time, but there is always a reason. We just need to keep searching. How are we going to assess joints, and how is that different from the muscles? Same thing, we're going to have it in our case history, the history of injury questions, and hopefully if there has been a prior joint dysfunction, that will be pulled out of that case history. In observation, we're going to look at how the horse chooses to stand again, bony alignment. In gait, we want to watch the horse moving and pay really close attention to the fluidity or the lack thereof. We want to look for skips in range, okay? So sometimes you'll see like almost like a double click, sometimes in the knee or in the stifle or the hock. So those types of skips in movement are important. And palpation, we're going to palpate the muscles, tendons, and if possible, the ligaments, depending on which surface we're looking at. And then we are going to do our range of motion testing. So range of motion includes the active range of motion, which is the gait evaluation, and the passive range of motion, which is going through every single joint systematically and checking all the ranges that it should have and matching that up with how it feels. Next, we're going to talk about the tendons. So as a reminder, tendons are dense, regular tissue, and they generally attach muscles to bones. I've put the arrow here, so we see the muscle coming down, becoming tendinous, and then inserting to the bone. Tendons have a little more give than ligaments because of what they're made of. So they've got a little bit more of that elastic component than ligaments. As a muscle contracts, the attached tendon is going to pull that bone into movement. So that's what's generating that movement. Tendon fibers, similarly to muscles, are typically arranged longitudinally and typically in line with the muscles to which they are inserting. The main function of tendons is to absorb impact from muscles as they shorten and lengthen, and to absorb those concussive forces, okay? So tendons take a lot of brunt because they're sort of that ending point that are tugging on the bone. And if we have repetitive strain happening, we can see why tendons would become inflamed or irritated. Here we have tendons consist of collagen and elastin, but collagen is mainly the component at 65 to 80%. And then elastin, approximately that remaining 15 to 20 of the dry mass. Since tendons are an extension of the muscle, they share many of the same characteristics in that they are extensible, they are excitable, they're innervated by the same nerves, they're able to contract, and they're also able to return to their regular shape. And they have that abundant blood and nerve supply, which is why tendons are generally easier to heal than a ligament injury. The most affected tendons in the forelimb are going to be the SDFT and the DDFT, our superficial digital flexor tendon and our deep digital flexor tendon. As we know, those are the two main tendons of the forelimb in the horse and the two most common sites of injury. Common tendon dysfunctions, I just touched on it. From a bodywork perspective, we're going to see a lot of strains and a lot of tendinitis. So irritation, inflammation of the tendon, or a strain, meaning micro tears in the fibers. Less common is the avulsions. So an avulsion is when the tendon, for whatever reason, has been pulled off of the bone and takes a piece of the bone with it off. So that's a lot more severe of an injury, and likely that horse is going to have been seen with the vet and probably having a regular veterinary visits because that's quite more severe. So in our bodywork perspective, we're generally seeing lots of strains, lots of tendinitis. Indicators of injury in tendons, heat, definitely, especially here, we can feel that quite easily because the tendons are very near to the surface of the skin. Tenderness and swelling, definitely if there's been an injury. So right here, we can see all that swelling, all the fluid backed up, and the swelling of the tendon itself. Same thing here, all this fluid indicates acute injury. And sometimes altered gait. So if it's just a mild strain to the tendon, we may not see altered gait. Or if it's tendinitis, as the horse warms up, we may see that their gait improves because blood flow is getting into those structures and helping to lubricate it, therefore making it a little bit more pliable. So remember, tendons are extensions of muscles. And what have I said about muscles? They are voluntary. So if there is a dysfunction in the tendon, we must again ask, why is the brain sending these signals to the muscle and thereby affecting the tendon? So unless the horse has had a blow to the leg or they've caught the leg in a fence and we know that there was a direct laceration to the tendon, that would be the only reason why I'm not seeking more answers because I knew what happened. But if it's this type of chronic repetitive cycle that we are starting to notice in a client horse, this is when we need to start asking these questions again regarding how the horse is moving, what the horse is doing on a regular basis, what the training schedule is, what the diet is, what terrains they're on, how is their feet, because we want to figure out why it is that these muscles are in a constant state of contraction. All right, now we're going to look at ligaments. Ligaments are the short bands of tough but flexible tissue. They're made up of lots of individual fibers and they attach bone to bone. So the major ligaments in the horse that we're going to talk about in the forelimb course is going to be, of course, the suspensory ligament coming down there. Ligaments always are connecting bones in the horse's body, and they're a lot less flexible than tendons. They're typically arranged cross-directionally. So that's a little bit different than tendons that are more longitudinal. The cross-directional sort of arrangement allows for greater tensile strength. Now, the number one function of ligaments is to provide a passive limit to the amount of movement available. So ligaments are there to check bones. So the reason why a bone doesn't dislocate is because the ligament is going to actually check that bone before it hits a dislocation range. So they play a very important role in keeping bones together and keeping joints together. We always want the ligaments to be somewhat taut, because that is the job of the ligament, is to check the bony movement. Ligaments are primarily collagen, okay? So very little elastin, which is why they're not so good at recoiling or going back to their original form once they've been overstretched or if they've been torn. So since collagen is less extensible than elastin, when the ligament is taken outside of its normal range of motion, it has a really hard time retaining its original shape because it just doesn't have those elastic fibers that cause that recoil. This is why sprained or torn ligaments really mean a lot of trouble. So not only is the horse owner going to have to deal with the ligament injury itself, but they're also going to have to be prepared that that joint is now going to be destabilized. Okay. And this is where you can come in and really help with that motor control homework and helping them to activate the muscles instead to help provide the support in the joints. Destabilized joints are also at greater risk of arthritis. This is why rehab is necessary. We must really include very thorough warm-ups to promote that blood flow, to promote synovial fluid production, because we are going to want to prevent risk of re-injury. So once the horse has injured ligaments, such as the suspensory, let's say, we really want to make sure that we're being thorough in their warm-up and that we're making sure to get body work done probably regularly to make sure things don't get so tight, and to prevent re-injury. All right, and then listed there, the most common ligament injuries in the forelimb are the suspensory, coming down there, sorry, there, yellow. The check ligaments, which are up top, holding the deep digital and superficial digital flexor tendons. And then the collateral ligaments aren't always talked about, but collateral ligaments are actually joining up every single bone. So they're always going to be on the sides of the bones and they're connecting the two bones together. So collateral ligament tears are very common in conjunction with other ligament tears like a suspensory. Now I wanted to show you this visual image of the difference between tendons and ligaments in terms of the fiber arrangement. I really like this one just because it's a very simple visual. We can see in the tendon, the collagen bundles are longitudinally parallel, like so. And then in the ligament, they're a little more cross-sectional, like so. Common ligament dysfunctions from our bodywork perspective is going to be the sprain, which is varying degrees of ligament overstretch or tear, and or a rupture. So rupture would be very severe, means completely torn in half. Again, that horse would be with the vet before they would be with us. There's some conditions such as DSLD, which is going to cause that extreme ligament laxity, and we're going to see the fetlock sinking, okay, when we're talking about the forelimb or the hind limb, when we really would want more of this type of angle coming down through the distal limb. So I like this visual as well because you can see the extreme stress and strain that's going through that joint, and we know that the ligament is not doing its job. Indicators of injury when it comes to ligaments, definitely heat and swelling. Again, not always palpable depending where in the body the ligament injury is. If it's in the distal limb, that's a little easier to find than if it was something up in the shoulder or in the hind end, like around the SI and hip. Again, very challenging. This is why we have to do our range of motion tests. So again, ask yourself why. Ligaments are involuntary, okay? They're non-contractile. Therefore, if there's dysfunction in a ligament, we must ask why it is that joint is destabilized, okay? So because we need to seek to remove a perpetuating factor if that is the reason that this is happening. So again, searching for these reasons. Why is this ligament destabilized? what is going on to cause this destabilization, and what can I do to assist the owner in removing any factors that are making it worse. How do we assess ligaments? You're starting to get the gist of it. Again, my case history, which is coming up in the next webinar. I'm going to show you all the questions that I have people fill out before I even come to see the horse. So I always want to know if there's previous injuries. Observation, again, we're going to look at how the horse is standing and what the bony alignment is. Just like in that last picture with the DSLD, that would have been very visible to see from an observation perspective, and I would have known right away that the suspensory ligament had damage to it. Gait evaluation, we always want to watch the horse in movement. When we're talking about ligaments, we're paying close attention to stability and potential hypermobility. So we want to see if those ligaments are actually checking movements or if the joints just keep going. We can palpate depending on where it is. Potentially we can palpate for heat or swelling or a palpable gap if it's one of the superficial ligaments. And then we're going to do our passive range of motion. So the way that we determine joint dysfunction versus ligament versus tendon is through the end feels. We will talk about end feels in our next lecture on building your assessment. But for now, you just understand that there is certain feels to certain tissues that give us information as to which tissue is the most affected. And then I love this picture because it brings together everything that we've talked about today. A nice example of all the tissues in action. So I love it. You can see the posterior ligament of the carpal joint. So right there. So we've got our ligament. We've got our collateral ligament here. Okay. So there's a collateral ligament, posterior ligament. We got our inferior check ligament. Okay. Then we've got our tendon of the DDFT, our tendon of the SDF, suspensory ligament. It's just really lovely photo to see all of these layers together. We even have the synovial sheath. Okay. So that's going around the tendon. And then, of course, the cannon bone. So we've got our bone in there as well. I have a quiz for you. Can you determine if this is a right or a left? I'm not giving you the answer. I'm going to need you to figure that out on your own because it's a great way to start training your eyes what you're looking at. So in summary, likely you're starting to see just how many different tissues there are and just how many tissues there are to assess furthermore. So this is why we need more tools beyond solely just palpating muscles, right? It only gives you one snapshot of information when there's a whole other body of tissues that we need to also be assessing. Muscles are truly the worker bees of the system. I hope if you take anything from this webinar, it is that I've said it over and over that because those muscles are voluntary, they're working, okay? They're worker bees for the nervous system. They're doing what they've been told. They're acting, carrying out orders that are being sent from the higher order of the brain. So when we see that they are dysfunctional, taut, rigid, or the opposite, flaccid or hypotoned, cool, we need to ask ourselves why. I'm sharing this with you because after running a successful practice for many years, almost 20 now, with horses and humans, these are the types of questions that I began asking myself about 10 to 12 years ago. I started wondering, why is it that what I'm doing, which was just massage at that time, wasn't always the answer for the horse, okay? I started wondering why, when I did all the techniques that I was trained to do, why the horse wouldn't get better, right? So this questioning of what is going on here led me to the education that I'm now sharing with you, which was developing the orthopedic assessment, starting in my pathway in osteopathy, where this is heavily taught in both of my trainings. This is a huge piece of the assessment process. And starting to get those questions answered because we simply weren't assessing and treating all of the tissues that are relevant when we're looking at, for instance, the forelimb. So I hope this lecture wasn't too much. I just really wanted to review the tissues because we, like I said, we're all coming in with different educations. And I just wanted you all to be on the same page about what it is that we're talking about when we're referring to muscles, tendons, ligaments, bones, and joints. All right, that's it. I hope you enjoyed this, and I will see you in the next webinar.